How do I get my Anyway, this is the Empowering Older Adults Opioid Awareness and Naloxone Training. So we're just going to start with the agenda. So what are opioids and why do we need to know about them? And the next one is what are opioids used for? Substance use spectrum, where are you on that spectrum? The substance use disorder, stigma, opioid safety, and nasal naloxone administration training. So opioids are used to reduce pain, and they are depressants. So that means depressants slow everything down. So they slow down your heart rate and they slow down your breathing, and they're highly effective, but they can be also highly addictive. Low doses can make you feel sleepy and free of pain, and higher doses can be dangerous and can cause breathing to stop, leading to death. These drugs can be used safely when prescribed by a physician and also used as prescribed. So examples of opioids include codeine, fentanyl, heroin, morphine, oxycodone, and OxyContin. In Canada, from January to June of 2023, the second highest proportion of accidental opioid-related hospitalizations were those aged 60 or more, and the highest was about only 1% higher. Usually, older adults have higher levels of pain, leading to higher treatment needs. And older adults, 3/4 of deaths associated with drug use are linked to opioids in older adults. Those over 65 have consistently received more new opioid prescriptions and have a higher proportion that go on to long-term opioid therapy than any other age group. So we're just going to look at a graph here. So this is the 2022 rate of opioid prescriptions for pain per 1,000 people. And blue is the Ontario rate, green is Brant, and their 20-year age brackets. The idea here is to notice how the rate of opioid prescriptions for pain, excuse me, goes up with each age bracket, and also to notice how Brant is higher than the Ontario rates in each age bracket. So compared to younger persons, older adults take more prescription opioids more often. This is related to more chronic pain in older people, increased side effects from other medications, and a false perception that older adults are unlikely to experience substance use disorder or to misuse their medication. Sorry, I'm just going to take a sip. So people's risk of substance-related harms can change as we age. There are some things that older adults should consider when deciding to use substances. So our bodies change as we age. As we get older, our bodies go through many changes that influence how substances can affect us and how strong their effects are. For example, you may have more body fat and less muscle mass than when you were younger. You may also have less water content in your body. Your body breaks down substances slower, so they stay in your body for longer. And this puts you at risk of experiencing the toxic effects of drugs when they build up in your body over time and start to cause effects such as blurred vision, dizziness, unsteady walking, nausea, diarrhea, poor concentration, and problems with memory, just to name a few. So this is the substance use spectrum. A person can move back and forth between stages over time. So it goes from non-use all the way through to substance use disorder. So it may be that you enjoy your coffee, and maybe that's at lower risk use, and you don't smoke, so you're in the non-use category there. However, maybe sometime you didn't drink coffee and you were in non-use, but you smoked at the higher risk use level. So people can change or move back and forth between stages over time and also between substances. So people use substances for different reasons, including medical purposes, religious and ceremonial purposes, personal enjoyment, or to cope with stress, trauma, or pain. Substance use is different for everyone and can be viewed on a spectrum with varying stages of benefits and harm. The 10 types of substances that fall within the spectrum include alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, stimulants such as cocaine and tobacco. So we have our non-use category at the one end, and that's basically abstinence. So it's avoiding use of all substances, no drugs, tobacco, alcohol, cannabis, or caffeine. Beneficial use is use that can have a positive health, social, or spiritual effects. So taking medication as prescribed, ceremonial religious use of tobacco, such as smudging, and lower risk use is use that has minimal impact to a person, their family, friends, or others. So it could be an example of drinking following the low risk alcohol drinking guidelines or cannabis use according to the lower risk cannabis use guidelines. Higher risk use is use that has harmful and negative impact to a person, their family, friends, or others. An example would be use of illegal drugs, impaired driving, binge drinking, combining multiple substances, increasing frequency, and increasing quantity. And finally, substance use disorder is a treatable medical condition that affects the brain and involves compulsive and continuous use, despite negative impacts to a person, their family, friends, and others. For example, when someone cannot stop using drugs, tobacco, cannabis, caffeine, or alcohol, even if they want to. So older adults have a decreased ability to process and break down opioids due to aging. Due to the higher use of other drugs that also affect the central nervous system, older adults are more likely to have a negative negative drug interactions that raise the risk of slowed breathing, putting them at more risk of overdose. So if we take opioid drugs for long periods of time, our bodies get used to them, and this is called tolerance. Because of this, the opioids can stop helping with pain the way that they used to. Older people are more likely to have overdoses from opioids than younger people, and sometimes opioids are highly addictive. So sometimes people start taking too much of their opioid medication to try to get pain relief. This could lead to overdose and death. People taking opioids need to be carefully monitored by their healthcare providers to minimize the risk. And people who take opioids are at risk of opioid use disorder. So opioids tell your brain that you feel good. They create a sense of well-being that is powerful, but lasts only for a short period of time. When an opioid dose wears off, you may find yourself wanting those good feelings back again as soon as possible. And this is how opioid use disorder can start. So potential side effects of taking opioids include nausea and vomiting, constipation, trouble urinating or peeing, drowsiness, falls, itching, confusion and changes in mood, heart attack, slowed breathing, sleep apnea, which is pauses in breathing or periods of shallow breathing during sleep, withdrawal, which includes pain, anxiety, insomnia, sweating, diarrhea, not a nice place to be, overdose, including death, and opioid use disorder. So possible signs of having an opioid use disorder. So I'm going to go through a number of symptoms here, and if you have experienced 2 or more of these symptoms in the last year, I recommend that you talk to your healthcare provider. So these are actually the diagnostic criteria that are used to determine if someone has a substance use disorder. So first one here is using an opioid, even though it has negative effects on personal life and your mental and physical health. Next one is using the opioid, even when it is not always safe to do so. Feeling the need to take more of the opioid to feel it working. Feeling like the opioid does not work as well as it used to. Taking a larger amount of the opioid than what was prescribed. Taking the opioid for a longer period of time than what was prescribed. Wanting to cut down and control intake of the opioid, but finding it difficult. Spending a lot of time taking and thinking about taking the opioid. Feeling like you must always take it. Having difficulty maintaining responsibilities at home or at work because of opioid use. So just going to go back here. So talk with your healthcare provider if you've experienced 2 or more of those symptoms in the last year. So we're just going to look a little bit at opioid use disorder. Opioid use disorder falls under the umbrella of substance use disorders. So opioids are considered one of the substances. So opioid use disorder is less likely to be discovered in older persons for several reasons. And that's that there are higher rates of fewer relationships with little to no social support or contact, having more than one disease or condition at the same time, challenges with the person's ability to think, learn, remember, use judgment, and make decisions, and low awareness among healthcare workers. For these reasons, older persons with opioid use disorder are less likely to receive treatment than younger people. So why is this important, you might be asking me? So Canada will likely see a growing number of older persons living with opioid use disorder. The reason for this is that our population is aging, simply. So there will be more people living with opioid use disorder. Also, there's a lack of awareness and stigmatization, which often prevents older adults from accessing vital harm reduction resources and services. So we're just going to talk a little bit more about stigma. So stigma is a set of negative and often unfair beliefs that a society or group of people have about something, such as the stigma associated with using substances. So there's stigma in language. Stigma often emerges in the form of derogatory language that shames and belittles people. And such language can lead to a cycle of behaviors and attitudes that isolate and marginalize people who use substances. Language is inaccurate, hurtful, and disempowering to vulnerable people. And we can help break down these barriers by changing the words we choose to use. And stigma is a major barrier to the well-being of people who use substances. So some examples of how stigma can make a person who uses substances feel include a sense of shame that stops you from seeking help, believing that as someone who uses substances, you will not receive help if you ask for it, and you are not heard, seen, or cared about. Stigma can make a person feel like their life doesn't matter. So 4 guidelines to using non-stigmatizing language. We're just going to go through those a little bit. So the first one is instead of using opioid user or addict, use person who uses opioid or who uses opioids. And this is person first language. So, person-first language is language that acknowledges someone as a person before describing their personal attributes or health conditions. Using person-first, non-stigmatizing language encourages people to seek help and increases the availability of and access to quality healthcare services. In short, person-first, non-stigmatizing language describes what a person has, not who a person is. It communicates respect and acceptance by stressing the fact that people with behavioral, psychological, or substance use issues are first and foremost just that, people. So the second one here is using language that reflects the medical nature of substances or of substance use disorders. And instead of abuser or junkie, use person experiencing problems with substance use. Number 3, use language that promotes recovery. So instead of unmotivated or non-compliant, use person experiencing barriers to accessing services. And avoiding slang or idioms. Instead of dirty or clean needles, use new or used. So a little bit about opioid safety. So always lock up your opioids, keep it out of reach and out of sight of children to avoid an accidental opioid poisoning. Never share opioids with anyone, including family and friends. And consider asking a pharmacist to help dispense your medication on a weekly basis because they can give you small amounts at a time. They can package your medicines in a way that can help you keep track, such as the blister packing, which I am a big fan of, labeled pill organizers, and can dispose of any unused opioids or any other medication for that matter. So having a naloxone kit in your home is also really important. And making sure someone that lives with you or who visits you often is trained in how to use it. Naloxone is a drug that has helped that helps to reverse an opioid overdose. It is given to a person through their nose or is injected into a muscle. We're going to focus, naloxone training is next, and we're just going to focus on nasal naloxone because it's much easier than the injectable. It's easier to use than the injectable is. So naloxone training, um, naloxone is a medication given to treat an opioid overdose. It displaces or kicks out the opioid from the receptors in a person's brain and then blocks those receptors and the effects of the opioid for approximately 30 to 90 minutes. So there's actually a lot of really important information in there. So naloxone only affects opioids. It doesn't affect anything else. And we're born with a whole bunch of opioid receptors in our brain, and that's why opioids work so well. And when the naloxone comes along, it's drawn so strongly to those receptors that it kicks out the opioids. So it's not affecting your brain or it's not affecting you anymore. And they kind of, work as goalies for about 30 to 90 minutes. That time is intended to find help for that person while they're once they've had an opioid overdose. So signs of an opioid overdose is breathing is slow, shallow, or gone. You may be able to hear a snoring or gurgling sound. Apparently it's called the death rattle. Apparently if you've heard it, you'll never forget it. Pupils will be very small. Lips and fingernails turn blue or purplish black. The person may be experiencing feelings of dizziness, confusion, or extreme tiredness. Skin feels cold or clammy, and a person is conscious or can't be woken up, or is unconscious, sorry. So what is a nasal spray naloxone kit? So in the kit, there's 2 nasal sprays. I believe the plungers now are red. There is a poster. It's 5 steps to respond to an opioid overdose. We'll go through that. There's also some gloves and a breathing barrier. We'll look at the breathing barrier as well. So how does naloxone work? So it stops the effects of opioids, but doesn't break down the drug. So if there are still drugs in somebody's body and the naloxone wears off, they can overdose again. And therefore they need to be monitored in a healthcare facility so that that naloxone can be administered again if as necessary. And it will not affect non-opioid drugs such as alcohol, other depressants, stimulants, or hallucinogens. More doses can be administered every 2 to 3 minutes if there is no response. And it sends the person into immediate withdrawal from opioids only. So as I mentioned, it's a really unpleasant space for people to be in. Naloxone, how does it work? So this is sort of a diagram of how what I was describing with the receptors and the opioids, and that the opioids are drawn and attached to those receptors. And then the naloxone has a stronger draw to the opioid receptors. And so it knocks the opioids off the receptors for a short time, and that allows the person to breathe again and reverses the overdose. So really what our goal is, it used to be to have the person come to, but now we just want people to breathe again because of the effects, or it's more street based, where the drugs are toxic because they're laced with other things. So 5 steps to respond to an opioid overdose. This is the poster that I was talking about that's in every kit. So the first step is shake and shout, call 911, give naloxone. If the person is not breathing, then you perform rescue breathing and or chest compressions. I recently had a CPR research, and the instructor identified that in adults, typically they have about 6 to 8 minutes of oxygen within their body. So they recommend, when naloxone first came out years ago, they recommended chest compressions only and didn't recommend the rescue breathing. The theory is that if they have 6 to 8 minutes, then you're pretty good for those first few minutes. But after that, the person doesn't have oxygen to flow to their brain. With 6 minutes of no oxygen, their brain cells start to die. So step 5 is checking if it's working. If there's no improvement after 2 to 3 minutes, repeating steps 3 and 4, stay with the person. If the person begins breathing well on their own, that's about 12 breaths a minute per se. So placing them in recovery position, and it's indicated here what recovery position looks like. And there's also signs of an opioid overdose listed beside the recovery guy. So, stimulation, try to wake the person, shout their name, shake their shoulders. Call 911, very important because you definitely want some help. Speaking calmly and clearly to the dispatcher, tell them the address and have someone wait outside if possible. I have been the person who waits outside in the past. I had to flag down the ambulance, and they drive like right at you. It's fantastic. It's really helpful for people, especially when they're looking for house numbers.
Brenda, we
Yes.
have about 2 minutes left for the presentation, okay?
Okay, I will make it fast. And then giving nasal naloxone. So we'll just remove the nasal spray from the box, peel back the tab with the circle on it, hold the nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Tilt the person's head back, support under their hand, or with your hand under their neck, gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the dose of naloxone. and remove the nozzle from the nostril once the dose is given. So with the breathing barrier, there's a one-way filter valve. It does prevent some germs, blood, body fluids, mucus, vomit from being transferred from person to person. It doesn't prevent transmission of COVID-19. It's recommended that people are fully vaccinated before they perform rescue breathing. So this is chest compression. So make sure to lay the person on a hard, flat surface, find the middle of the person's chest or their breastbone. Hands are one on top of each other, elbows are locked, push down hard and fast with the heels of the hand, and continue until EMS arrives. So checking if it's working, this is putting the person into recovery position. The person may wake up suddenly or slowly, may be confused, angry, agitated, and combative, may want to use more drugs and remain unconscious, but start breathing again. So if the person has not started breathing on their own in about 2 to 3 minutes, give a second dose of naloxone using the other nostril. And so if you can't get to the floor, have a safety plan in place. You can do the shout portion, you can get help, you can get your naloxone kit, you can call 911 and tell the helper how to administer the naloxone and tell the helper how to perform chest compressions and or rescue breathing. So after an overdose, it can be traumatic for everyone. Talk with people around you who support you or a healthcare professional to share your experience. Ensure that everyone in your life knows that you carry a naloxone kit and replace your used naloxone kit with a new one. Don't store it in your glove box. Store in blister cartons at room temperature. You can get it up to 40 degrees Celsius, but we're uncertain how many times that can occur before you affect the naloxone in the nasal spray. If it's expired, take it back, get a refill. And in Brantford, you can go to some pharmacies, call before you go. You can get at the Grand River Community Health Center at the Brant County Health Unit. And in the County of Brant, you can get it at the public libraries at all 5 sites. So key messages are substance use occurs on a spectrum. Consider where you are on that spectrum. Opioids are highly addictive. Older adults are at risk of opioid overdose. And when in doubt, give naloxone. In the worst case scenario, it will simply do nothing. In the best case, it will save a life. There's no harm caused to a person receiving naloxone when they have not overdosed. Naloxone only works on opioids, and have naloxone in your home. Make sure everyone knows that you have it. And that's all.